Renal function. All right, so an overview of non-protein nitrogen compounds. This refers to a group of nitrogen-containing compounds in the blood that are not part of proteins. So these compounds are important clinical markers because their levels in the blood provide insight into renal function and metabolic status. So some clinical importance of this, the most clinically relevant compounds used to monitor kidney function include urea, which are produced from the breakdown of amino acids. Elevated levels often indicate reduced kidney clearance or increased protein catabolism. Creatinine is a breakdown product of muscle creatine phosphate, widely used as a reliable marker for glomerular filtration rate and kidney function. Uric acid, which is the end product of purine metabolism. It's elevated in conditions like gout and renal impairment. And then we also have ammonia, which is generated from nitrogen metabolism. Its elevated levels can indicate hepatic dysfunction or renal failure. So measurement of these compounds can help evaluate the renal clearance capacity. Abnormal levels may reflect renal insufficiency, acute kidney injury, or chronic kidney disease as well. These markers can also help guide clinical decisions like diagnosis, monitoring, and treatment of renal disorders. So, blood urea nitrogen, or BUN, this is formed in the liver as a byproduct of protein metabolism. It originates from carbon dioxide combining with ammonia, and that forms urea, which is then released into the bloodstream. Urea is transported by the blood to the kidneys where it is filtered by the glomerulus and excreted in urine. If you have elevated urea levels, so an increase in blood urea levels is referred to as azotemia. When elevated urea levels are accompanied by clinical symptoms such as nausea, fatigue, and neurological impairment due to renal failure, this condition is called uremia or uremic syndrome. Uremia is a life-threatening condition and requires urgent intervention, often dialysis, and that helps to remove the accumulated toxins. Without dialysis or treatment, it can be fatal. Different categories of azotemia can be classified into three different categories. So we have pre-renal, which is caused by decreased blood flow to the kidneys, like dehydration or heart failure. And then we have renal, which is due to intrinsic kidney damage, which affects filtration, so glomerulonephritis or acute tubular necrosis. And then we have post-renal, which results from obstruction of urine flow, so kidney stones or prostate enlargement can all cause that. All right, so pre-renal, going back to that, it occurs due, like I mentioned, to reduced renal blood flow, leading to decreased uric acid clearance. Common causes include congestive heart failure, shock, hemorrhage, dehydration. In these conditions, the kidneys will receive less blood, which impairs filtration and causes uric acid to accumulate in the blood. Then we have renal hyperuricemia. That results from decreased renal function or direct kidney damage. And that's seen in acute renal failure, chronic renal failure, glomerulonephritis, and acute tubular necrosis. The kidney's impaired ability to excrete uric acid leads to its buildup in the plasma. And then we have post-renal. That's caused by obstruction to urine flow anywhere in the urinary tract. So some causes of that could be renal stones, if there's tumors of the bladder and the prostate, or severe urinary tract infections. Obstruction prevents normal uric acid elimination, and that leads to the elevated blood levels. Low plasma, or low urea plasma, can result from a decrease in the amount of urea present in the blood. This condition reflects reduced urea production or altered metabolism rather than kidney dysfunction. Some causes of low plasma urea, so we have decreased protein intake. So since urea is a byproduct of protein metabolism, low dietary protein intake can reduce the amount of urea that's being produced in the liver. Severe liver disease, so the liver is responsible for converting ammonia into urea through the urea cycle. In cases of severe liver dysfunction or failure, this process is going to be impaired, which is going to lead to a decreased urea synthesis, and consequently, you're going to have lower plasma urea levels as well. The BUN creatinine ratio. So the normal ratio is going to be 10 to 1 or 20 to 1. This ratio helps clinicians evaluate the cause of azotemia and differentiate between types of renal dysfunction. So if you have pre-renal azotemia, it's going to be characterized by an increased BUN level with a normal or near normal creatinine level, which leads to a high BUN creatinine ratio. A post-renal will show a high BUN and creatinine ratio accompanied by increased creatinine levels. And for low BUN creatinine ratio, this is seen in conditions where the BUN is disproportionately low compared to creatinine, leading to a reduced ratio such as low protein intake, acute tubular necrosis, or severe liver disease. Methods to measure urea. Urea concentration is commonly measured to assess the renal function. There are two main methods used in the clinical lab. Method 1 is hydrolysis of urea to ammonia. So urea is hydrolyzed to ammonia using the enzyme urease. The released ammonia is then detected by Nessler's reagent, a colorimetric method producing a yellow-brown color, and Berthollet reaction, which is another chemical detection method. This method is simple and widely used, but can be influenced by interfering substances. And then method 2 is the kinetic enzymatic method. This couples urease with glutamate dehydrogenase. This method monitors the rate of disappearance of NADH spectrophotometrically. It provides rapid, accurate, and automated measurement of urea. Specimen handling, so urea can be measured in serum, plasma, or urine, and it's important to avoid anticoagulants like sodium fluoride and sodium citrate because they could interfere with the assay. Hemolysis can also interfere with the assay as well, and then the normal reference range is between 7 and 18. Creatinine is synthesized primarily in the liver from the amino acids arginine, glycine, and methionine. After synthesis, creatinine is transported to muscle tissues. In muscle tissues, creatinine is converted into phosphocreatine, which is creatine phosphate. Phosphocreatine serves as a rapid reserve for high-energy phosphate groups essential for muscle contraction and energy metabolism. So creatine phosphate spontaneously converts to creatine phosphate spontaneously converts to creatinine, which is a waste product. Creatinine enters the plasma at a constant rate, which is directly proportional to muscle mass. Creatinine is removed from circulation primarily by the glomerular filtration in the kidneys, and then it's excreted through the urine. So clinical significance of this, so because creatinine production is relatively constant and dependent on muscle mass, serum creatinine levels are widely used as a marker of renal function. Changes in serum creatinine concentration can indicate alterations in the glomerular filtration rate and the kidney health. Increased plasma creatinine levels are closely associated with abnormal renal function, particularly impaired glomerular filtration. Since creatinine is cleared almost exclusively by the kidneys, elevated levels suggest reduced glomerular filtration rate. So the GFR, or the glomerular filtration rate, is defined as the volume of plasma filtered by the glomerulus per unit time. It reflects the kidney's ability to filter blood and is a critical measure of kidney function. So the formula for the GFR is U times V over P, where U is the concentration of creatinine in urine, V is the urine flow rate, so it's the volume per unit time, and P is the plasma concentration of creatinine. And I believe I have a video on the next slide, so what to show you. But then we also have the clearance, and clearance of a substance is the volume of plasma completely cleared of that substance by the kidneys per unit time. It can help quantify kidney function and evaluate how efficiently kidneys remove substances like creatinine. So sometimes you have to adjust the GFR for body surface area. So since kidney function varies with body size, GFR is often corrected for the body surface area to standardize measurements, allowing comparison between individuals of different sizes. GFR versus the E, or estimated GFR, what's the difference? GFR is the direct measured filtration rate by kidneys. requiring urine and blood samples. So it needs both, it needs urine and blood, where the E, or the estimated GFR, is a calculated estimate from blood, creatinine, and demographic data. So they don't need a urine sample for that, they just need blood. So the GFR is the actual volume of plasma filtered by the glomeruli per unit time, usually measured in milliliters per minute. It's measured traditionally by creatinine clearance using urine and plasma creatinine levels. And again, it's a 24-hour urine collection. It requires both, like I said, urine and blood, and it's considered a direct measurement of kidney filtration. So pros of doing this: it's more accurate if it's done correctly, and reflects the true kidney filtration performance. Cons: it's time consuming and inconvenient to do a 24-hour urine collection, and it's subject to collection errors. So you have to trust that your patients are doing it appropriately. So that's where the estimated GFR comes into play, and that's an estimate of GFR derived from mathematical formulas using only the blood serum creatinine, along with variables like age, sex, race, and sometimes body size. So there's a couple different formulas, but the one I have listed down below is the one that's kind of more widely used as of right now. Pros for this is it's quick, easy, and there's no need for a urine collection. It's useful for routine screening and monitoring kidney function. Cons: it's an estimate, so it can be affected by factors that can influence creatinine levels like muscle mass, diet, and medication. It's also less accurate in extremes of muscle mass or unusual body compositions. So the relationship between plasma creatinine and renal function is if there's an increase in plasma creatinine, there is usually a decrease in the GFR. That indicates a renal damage or impaired kidney function. For clinical use, we can use plasma creatinine. It's one of the most commonly used markers to monitor the renal function. To do that, we use the Jaffe reaction. So the creatinine reacts with picric acid in the alkaline solution, and that forms a red-orange chromogen, and that's the traditionally widely used method, so make sure you remember that one. Kinetic Jaffe method, so how it does it is it measures the rate of change in absorbance due to chromogen formation, and it improves specifically over the classical Jaffe. Coupled enzymatic methods use enzymatic reactions specific to creatinine. It's generally more specific and accurate than the Jaffe methods currently. So, always coming out with new things. So that's why we do continuing education, right? Specimens for creatinine measurement: you can use serum, plasma, and urine. Some pre-analytical considerations is to avoid hemolysis, avoid icteric samples, avoid lipemic samples. For urine specimen storage, make sure you refrigerate or freeze it. And if it's stored for longer than 4 days, or we need to freeze it if it's going to be stored longer than 4 days. Then the reference range for plasma and serum creatinine is 0.6 to 1.2. Uric acid. This is the final breakdown product of purine metabolism. Purines are converted to uric acid primarily in the liver. Renal handling, so uric acid is transported to the kidney and filtered by the glomerulus. 98 to 100% is actually going to be reabsorbed in the renal tubulars, meaning very little is excreted under normal conditions. So some clinical significance: uric acid can precipitate and form crystals in tissues in urine, and these crystals may contribute to conditions like gout and or kidney stones. So diseases that are associated with an increased uric acid level, gout is kind of one. It predominantly affects males between 30 to 50 years old. It is characterized by pain and inflammation in joints, and that is due to the uric acid crystal deposition. Uric acid or serum uric acid for gout is usually greater than 6. It can lead to formation of renal calculi or kidney stones as well. Increased nuclear catabolism is seen in conditions with rapid cell turnover or destruction, like chemotherapy, leukemia, lymphoma, hemolytic anemia. Things like that can lead to increased breakdown of nucleic acids, resulting in elevated uric acid. And then we also have renal disease, which can be an impaired excretion causes, your uric acid to accumulate. The mechanism of increased uric acid, so kidney damage reduces glomerular filtration rate, or your GFR, so less uric acid is going to be filtered out. Impaired secretion of uric acid in the renal tubules further reduces elimination. So the result of that is uric acid will accumulate in the blood, which will then cause hyperuricemia. So clinical relevance of this is high uric acid can worsen kidney function by promoting crystal deposition. Or it may contribute to gout in these patients as well. Toxemia of pregnancy or preeclampsia and lactic acidosis can increase uric acid. So toxemia of pregnancy, there can be placental ischemia, which leads to increased cell breakdown and reduced renal clearance, which can then once again raise uric acid. And then lactic acidosis, which is where there is excess lactate, which competes with uric acid for renal excretion, reducing uric acid clearance. So some clinical relevance on this. So if you have elevated uric acid levels in pregnancy, it can be an early marker for preeclampsia. We're going to monitor the uric acid, which will help, assess the severity and progression of this as well. Now we're going to talk about decreased uric acid. So this can happen in liver dysfunction, which impairs purine metabolism, which reduces the production of uric acid. Also may affect synthesis of enzymes involved in uric acid formation. Clinical relevance, again, we have low uric acid levels, can also indicate severe liver damage and impaired metabolic function. Let's see, defective tubular reabsorption, renal tubular defects reduce the reabsorption of uric acid back into blood, and then this can cause increased uric acid loss in urine, which will then lower plasma levels. May be seen in rare inherited tubular disorders or drug-induced tubular damage. To analyze uric acid, we can use the Caraway method. This is when uric acid is oxidized, which leads to the reduction of phosphotunxic acid to a blue-colored compound called tungsten blue. Specimen types we can use are serum, plasma, and urine. Some pre-analytical considerations is we want to remove serum from the cells as soon as possible, and this helps to prevent degradation or interference. We want to avoid grossly lipemic samples as well, as it can interfere with the assay. Reference ranges are 3.5 to 7.2. And then we move on to ammonia. Ammonia is primarily produced by the deamination of amino acids. It's a process where the amino group is removed from the amino acids during the protein metabolism. Significant amounts are released from skeletal muscle during intense exercise when amino acid catabolism increases to supply that energy. Additional ammonia is generated by gut bacteria during protein digestion. Ammonia metabolism. So ammonia is highly toxic and must be efficiently removed from the bloodstream. It is transported by the portal vein to the liver, where it is converted into urea by the urea cycle for safe excretion by the kidneys. So ammonia with liver disease, there's liver function impairment. So in severe liver disease like cirrhosis or hepatitis, the urea cycle is compromised due to loss of hepatocyte function. This causes accumulation of ammonia in the blood, which is called hyperammonemia. Some consequences, so elevated ammonia crosses the blood-brain barrier, which can lead to neurotoxicity. Ammonia disrupts neurotransmission, cerebral energy metabolism, and causes astrocyte swelling due to increased glutamine production, contributing to brain edema or brain swelling. Some clinical manifestations, it can result in hepatic encephalopathy, which is characterized by cognitive dysfunction, so confusion. They can have personality changes. They can have altered consciousness, which can progress to a coma. Some other causes of increased ammonia can be inherited urea cycle disorder, genetic enzyme deficiencies leading to failure to convert ammonia to urea. Renal failure is another one. It's an impaired excretion of urea and ammonia. Then you have GI bleeding, which is an increased protein load in the gut. It increases ammonia production. To diagnose and monitor this, the blood ammonia levels are measured to assess severity of liver dysfunction and encephalopathy risk. This is going to require careful sampling. We just need to be careful with these because they're kind of fussy. And then your normal reference range is between 15 and 45. Some clinical conditions associated with elevated ammonia levels is a hepatic failure. So hepatic failure leads to impaired ammonia metabolism due to loss of functional hepatocytes and compromised urea cycle. This results in accumulation of ammonia, which we mentioned earlier. Clinical importance, so monitoring the blood ammonia level is going to be crucial in your hepatic failure. Once again, to assess the severity and predict the prognosis, we also want to track the risk of them developing hepatic encephalopathy. Then we have Ray's syndrome, which is rare but often fatal condition that can primarily affect children and adolescents. This typically occurs following a viral infection, something like influenza or chickenpox. It's characterized by fatty infiltration of the liver and cerebral edema. Ammonia levels will correlate strongly with disease severity and patient prognosis. Elevated ammonia contributes to the neurological symptoms seen in Ray's syndrome. So clinical significance of this, early measurement ammonia can help to diagnose and manage Ray's syndrome, helps to differentiate from other causes of encephalopathy in children. To measure ammonia or to analyze it, ammonia is usually really low in the blood already, so that makes it really difficult to detect. Sample instability also makes it very difficult to detect. So, ammonia levels can change rapidly after the sample collection because the metabolic processes keep on going. There's also contamination risk. Ammonia contamination from environmental sources or improper handling can also elevate results falsely. But when we can test for it, we have a coupled enzymatic assay. The principle of this is the ammonia reacts enzymatically, leading to the decrease in absorbance at 340 nanometers due to the conversion of NADPH to NADP. The rate of absorbance decrease is proportional to the ammonia concentration in the sample. So sample requirements, venous blood, again, we're going to want to be kind of careful with these. We want to avoid traumatic draws. We don't want it to be hemolyzed. We need to place it on ice immediately after you draw it, and this helps to prevent an increase in ammonia or having it decrease in there as well. And we're also going to use an EDTA or a lavender tube as the anticoagulant. Once it gets back to the lab for processing, we are also going to centrifuge this specimen at 0 to 4 degrees Celsius within 20 minutes of collection. And we are also going to want to remove plasma immediately as soon as it is centrifuged and analyze or store it properly, right away. As mentioned, you want to avoid hemolysis. Hemolysis releases those intracellular ammonia and other substances that can falsely elevate ammonia levels. And for patients, they should avoid smoking for several hours before blood draw because smoking can actually increase the blood ammonia levels and can affect the test accuracy.